Good afternoon, everyone. Today we'll be discussing about sympatholytics. As the name itself suggests, we can simply define the term into two parts, sympatho and lytics. So basically how we are going to define it, but before that we will understand lytics means anything that blocks the function of sympatho, here terms for sympathetic. So anything that blocks sympathetic system. So, the what are we going to say is drugs that antagonize the receptor action of adrenaline and the related drugs. So, as we know that there are receptors present in our body, alpha receptors and beta receptors. So, in order to block them, these include two types of drugs: alpha adrenergic blockers and beta adrenergic blockers. Alpha blockers. This is the classification of alpha adrenergic drugs. These are of two types: non-equilibrium type and in equilibrium type. In this, it is further divided into three on the basis of the receptors present in them. For example, in non-selective one. In non-selective, we find both type of receptors, alpha 1 and alpha 2. So if something is in these drugs are not blocking any specific receptor, so these are non-selective. In alpha 1 selective, drugs will be blocking the alpha 1 receptors, and in alpha 2 selective, it will be blocking the alpha 2 receptors. Beta blockers. Beta blockers are further divided into same non-selective and cardioselective. Since as we know, beta 1 receptors are found in heart, so the first classification of drug would be cardioselective, since beta 1 receptors are present in our heart. Non-selective one, we have beta 1 and beta 2 receptors. So the drugs acting on these receptors will be blocking beta 1 as well as beta 2. Before we move ahead, we will talk about where beta 2 receptors are present, as we will be solving a question that will be coming in front of the slides. Beta 2 receptors are present in three places. First is bronchus, where it causes bronchodilation. Secondly, it is present in blood vessels, where it causes vasodilation. And third, in liver, where it performs the function of reverse hypoglycemia, which is important in diabetes mellitus. Uses of alpha blockers and beta blockers. Alpha blockers is used in pheochromocytoma. In this, phenoxybenzamin is used. Phenoxybenzamin is used in these because these are non-reversible. So when something is non-reversible and it attaches with the receptor, so it has a long-term output. Then we use it in hypertension, since as we know, alpha 1 receptors does the process of vasodilation, so vasoconstriction. So in order to vasodilate it, we can give beta blockers that will reduce the blood pressure. We give it in benign hypertrophy of prostate. In this, there are two types. One is static obstruction and another one is dynamic obstruction. Alpha blockers are given in dynamic obstruction. Static ones are those in which there is change in the size of the prostate, whereas in dynamic there is just the flow. Either there will be muscle tone changes, or there will be obstruction in the path that we relax. So prazosin-like drugs are the drugs of choice in such cases. Then we have peripheral vascular diseases. Then alpha blockers are also used in phenolphthalein-induced penile erection. In these, injection of piperacin with or without phenolphthalein is given in corpus cavernosum. Beta blockers are again used in hypertension because they perform the function of vasodilation, which decreases the blood pressure. Then it is used in angina pectoris, cardiac arrhythmia, myocardial infarction, and congestive heart failure. So when we talk about the adverse effects of alpha blockers, it will be tachycardia, palpitation and arrhythmias, angina and myocardial infarction. Selective alpha 1 blockers are used as these are used in the postural hypotension and syncopal attacks. This is a first dose mechanism. These selective alpha 1 blockers are generally advised to give at the bedtime. We cannot say we should give it at night, as night there are people that are awake all night, so we will be giving it in bedtime before the person is going to, so that person can have a rest and we can avoid these postural hypertension and syncopal attacks. Next we have nasal blockage. It blocks the blood vessels which leads to stiffness, and then it blocks the dilator pupillae. Dilator pupillae have alpha 1 receptors, so it will cause the meiosis, shortening of the pupil. Then we have adverse effect of beta blockers. Bradycardia and heart block may precipitate CHF in patients with low cardiac reserve. Beta blockers can precipitate angina due to unopposed alpha 1 action. It causes bronchospasm in patients with asthma and COPD. So now we have a question that why beta 2 blockers are not preferred in asthma, PVD and diabetes mellitus. Anyone would like to answer? Okay, so we just saw that beta 2 blockers are present in bronchus, blood vessels and liver. So what the function they are performing there in bronchus is causing bronchodilation. So if we block these receptors, this will lead to bronchoconstriction, and that is not a good thing in asthmatic patients. In blood vessels, it again is causing vasodilation. So now we will be, if it is causing vasodilation and we are blocking these receptors, then we will be if we are blocking these receptors, then it will again lead to vasoconstriction. That is not a good indication in peripheral vascular diseases, those who are having peripheral vascular diseases. In the liver, we have seen that in liver the function is to do reverse hypoglycemia. If this receptor is being blocked, then there will be no reverse hypoglycemia, and that will lead to diabetes mellitus. So in these three cases, we never prefer to give beta 2 blockers. Instead, we give beta 1 blocker. Prefer. So the contraindications here, as explained, asthma and COPD, it causes severe bronchospasm. So beta 1 selective are preferred over here. Non-selective beta blockers in diabetics increase the risk of hypoglycemic episodes, and partial and complete heart block causes bradycardia. So now we come on some interactions. Verapamil is a calcium channel blocker, and if it is given with the beta blockers, they cause additive depression of sinus nodes, cardiac arrest can occur. If oral antibiotics, if these are given in oral antibiotics, it masks the warning sign of hypoglycemia. So the warning signs of hypoglycemias are tachycardia, sweating, and if the person cannot, if there are no signs, then person will not be able to understand that he has to take some glucose. So this is known as the oral antibiotics is considered as to mask the warning sign of hypoglycemia. Alpha agonists cause marked rise in blood pressure due to the blockage of sympathetic vasodilation, and NSAIDs attenuate antihypertensive actions of beta blockers. So this was we discussed.